Well, welcome everyone to our first clinical session of 2021. We're so thankful for all of you being here today for our lecture with Dr. Arshid Qayyumi. So before I introduce our moderator, Dr. Hussein Shabi, I'll introduce our Chancellor of Sadiq International Virtual University, Dr. Shabi Zaidi from the UK.
Assalamu alaikum, good morning, good afternoon, good evening. Thank you, Shifa. It is a great privilege to welcome Arshid Qayyumi once again. He is the most renowned cardiologist and speaker that I know. Hussein will introduce him, but allow me to say that we've had a wonderful session this morning. We started the clinical scenarios interactive, more like simulated structured program. So Dr. Fahim and Jani did it this morning from St. George's in London. And we had a gathering of final year students and postgraduates from different countries. It was amazing. About 75 to 80 people joined in. Following that, now this is the beginning of the clinical sessions. Last year, SIVU conducted a whole series of webinars and workshops only related to medical education. So we've created or carved out a niche for ourselves in the field of medical education. But clinical sciences are important because IMI is loaded with top-class clinicians and physicians. So this is the first series of webinars and lectures and interactive discussions that will start in a moment. So I'll hand you over to Hussein Shabi, and he'll introduce the speaker and conduct the whole session. Thank you. Over to you, Hussein.
Thank you, Professor Shabi. Well, it's an honor to be introducing Dr. Qayyumi, who really requires no introduction in this field. He's an eminent, world-renowned cardiologist. He's contributed hugely to the field of cardiovascular science and clinical translational research. During my own research, I read many of his papers and journals and quoted them. He serves on many editorial boards of several international journals, several advisory boards. He's worked in renowned centres in London, UK, and USA, and he's currently Professor of Medicine at Emory University School of Medicine and Director of the Emory Clinical Cardiovascular Research Institute. And there's no one better who can now tell us about updates on diagnosis and management of coronary artery disease. Dr. Qayyumi.
Thank you very much. Thank you. Very flattering introductions. I hope the rest of the hour lives up to this. So what I'm going to do, if I can make this move, is to talk about coronary artery disease. And this is a huge subject, of course. So I'm going to spend time talking about some perhaps concepts that have changed since perhaps you have gone to medical school or have seen it practiced. So perhaps some updates on things that we now are beginning to think of differently. I'm going to show you some data about how we might do things in the future and that kind of thing, and not really get into the nitty-gritty of how we treat this on a day-to-day basis, which is pretty well known. So the reason one of the reasons why we think so much about coronary artery disease or heart disease is because it's one condition that's going to kill most of us. So around in the US, for example, 34% of women and 32% of men will die from coronary artery disease and its complications. So it's the most common cause of death and morbidity. But in addition to that, it is very costly to manage this disease. And even though only about a third of us are going to die from this, it's worth remembering that a majority of adults, particularly in the Western world, but now also around the world, will actually develop some element of coronary artery disease, even though it will not lead to their demise, but they will develop it during their lifetimes. And I'm going to spend a little bit of time talking about each of these subjects, so I'm going to rush through them fairly quickly. But just to give you a flavor of how we think of this, perhaps, especially on the investigational side, but start with a case a typical case, this could be somebody in your family, for example. This is how people present. So here's a youngish man, 45-year-old, of South Asian origin, who has a history of diabetes and dyslipidemia and used to smoke, and had a 1-month history of occasional discomfort, which he used to think of as indigestion, which would occur when he walked or with emotional stress. And then before admission, he had more severe pain. And he has a pretty stressful job. He has a family history of coronary artery disease. His brother had angioplasty age of 56. He is on some medicines. He's on aspirin and pravastatin, which is a statin, a weak statin at a low dose, and metformin for his diabetes. And though you see the numbers there, his LDL is 90. These are now US units, I hope. I don't think it will make any sense in the UK, but that's not ideal. HDL is low, triglycerides are high, and A1C is 7.5. And his blood pressure is 135/82. His BMI is up a little bit, 28. And he has some ST segment elevation inferior leads, suggesting he is having an acute MI. He's taken to the cath lab and found to have an occluded right coronary artery. Ejection fraction is just below normal. So here's the angiogram of his right coronary artery, and you see this narrowing here. And he gets angioplastied and stented, which is standard practice, and his artery is now completely open. And he's recovered fully from this without much damage. He has now got a series of questions which allows us to get into the etiology of this condition. And one of them is, why did I have heart disease, and what could I have done to prevent it? So this gets us into risk factors. How does one get coronary artery disease? This is pretty common knowledge, but here's a study, for example, that was done internationally, 50 countries, thousands of people, and controls from the same hospitals as people were being admitted for myocardial infarction. And it looked for differences between the controls and people who came in with myocardial infarction. And there were 9 risk factors that were thought to be significant predictors of the group that had myocardial infarction. So age was important. This is ApoB to ApoB1 is like LDL to HDL, or similar to that. So this is dyslipidemia, higher LDL values, lower HDL values, smoking, diabetes, hypertension, abdominal obesity, psychosocial stress. And there were factors that were beneficial. People who had excessive intakes of fruits and vegetables were less likely to have myocardial infarction. People who exercised more or less, and also people who had some alcohol intake had less likelihood of myocardial infarction. So there were preventive factors and provoking factors, or if you like, injurious factors that were responsible for this. So these are considered as so-called risk factors for coronary artery disease, and these particular ones for myocardial infarction. Some of these are modifiable, others are not. And if you now if he had gone to his doctor, a week before, a month before, or whenever before this event occurred, and said, do you think I have heart disease? Then the way we kind of handle this, or have done for years, is we look for myocardial ischemia. So what's myocardial ischemia? Here's a depiction of what a coronary artery looks when we are born. So it's smooth, it's in endothelium is normal, it's a smooth muscle layer, the lumen is completely open. And this is an artery as it gets atherosclerosis, so the plaque is within the wall of the artery, and that as it impinges into the lumen gets narrower and narrower. And it's this reduction in blood flow, particularly noticeable when you exercise, etc., when you are trying to increase cardiac output and therefore coronary blood flow. It's unable to increase the blood flow because the artery is now blocking up. And that leads to ischemia and can be manifest as symptoms of chest pain and occasionally of shortness of breath and so on. So this is the standard sort of angina and why it occurs. It's this reduction in the lumen of the coronary artery, reduction in blood flow in the setting of increased demand that leads to myocardial ischemia. So here we have this usual scenario that we followed for decades. Risk factors, some of them are modifiable, some of them like aging, et cetera, are not, that lead to coronary artery disease or atherosclerosis that ultimately lead to not just angina, but some bad events such as myocardial infarction, which damages the heart and can lead to heart failure, peripheral arterial disease, meaning the same occurring in the cerebral circulation or in the leg circulation, and of course, sudden cardiac death. So this is a disease where the first manifestation of this could be sudden cardiac death. So you don't actually have an indication that you have the disease, but the first event is where there's sudden cardiac death. So a way we have dealt with this is, if that question is asked, is that we put people on a treadmill or a bicycle, we exercise them, we watch the electrocardiogram, particularly the special changes that occur in the ST segments, which are considered a pathognomonic sign of myocardial ischemia. So you have your EKG attached to you while you do all of this. And as the level of exercise is increased in a graded fashion, these changes occur if there is occlusion or partial occlusion of the coronary arteries that leads to this imbalance, and that leads to ST segment depression. Nowadays, this is combined with imaging modalities such as nuclear stress testing, which gives you pictures of the myocardium and the uptake of the radioisotope, usually technetium, or you can do echocardiography around the exercise to see whether there is wall motion abnormality. So you look for other changes associated with ischemia that make the test much more reliable, if you like, whereas the ST segment changes on the stress test is not such a reliable test. It's only positive in about 60-65% of the cases. Then years ago, when I started to get interested in cardiology as a sort of resident, in the UK there was the Holter monitors were invented, which were digitized such that you could record ECGs in a very faithful fashion. And then you could record ST segment depression during normal daily activities. So people with coronary disease would walk around with these things for 24, 48 hours and have lots and lots of episodes of a transient ST segment depression during their normal daily activities. Often not associated with pain. In fact, 90% of episodes that occur in people of ischemia, because this is ischemia, which are transient, are not associated with pain. So the fact that we wait for people to complain of pain, of anginal pain, before we investigate them is particularly a misguided approach, because you're going to miss the majority of individuals, because some of us will never have pain with ischemia. Others will have lots of pain, and most of us will have majority of ischemia that is silent. And we learned that the ischemia occurs mainly in the daytime hours, very little in the nighttime hours, and so on. And we followed these people up for prognostic reasons. We studied them at night and during the day and saw the characteristics of all of this. This became a huge thing in the sort of late 80s, early 90s. There was even a Time magazine article about the silent killer, because we felt that we had now found the sort of clue to how to detect people with coronary disease much earlier than they would have otherwise found out by looking for silent ischemia. However, when we followed these people up over time to see how well they did, we found that there was no prognostic value of knowing whether or not you had ischemia. So this was a shocking revelation, which is that you could detect this and you knew why it was occurring. It was because of a blocked artery. And yet, people who had it versus people who didn't have it had no difference in outcomes. And in fact, the artery that was narrowed because we did angiograms like you saw earlier, and all of these people, we realized that the angiograms were not predictive of where the myocardial infarction or the acute event was occurring. In fact, in people who did have a heart attack during follow-up, the angiography showed that the total occlusion, which is what occurs during a myocardial infarction, was occurring at vessels which were not significantly narrowed to begin with. So insignificant plaques was where the blockages were occurring. So here's a depiction of, if you like, of a coronary artery that develops atherosclerosis over time. Remember, this is what we are all going to get, about 90% of us. So we're born here, very normal vessel, then slowly the plaque develops, and this takes decades and decades. And once in a while, or one or two areas might develop very severe narrowing. This is when you get angina. But the myocardial infarction or sudden cardiac death occurs in plaques often that are not significantly narrowed, but they're insignificantly narrowed. But they have a plaque cap that is thin and vulnerable to rupture. And when it ruptures, it causes, which is an accidental event, it causes thrombus formation and total occlusion. That's your myocardial infarction. So this person that we saw who had an occlusion of his or near occlusion of his coronary artery, this is what the lesion looks like. Very severely obstructed, fibrotic plaque, lots of calcium in it and so on, but very stable. It's not going to rupture or very unlikely to rupture. Whereas the area that's going to rupture is going to be insignificantly narrowed. There will be a plaque, but the plaque will have very different characteristics from this plaque, where this will have a necrotic core, very thin cap, which is liable to rupture. And when it ruptures, it causes formation of this clot within the next few minutes. And that leads to total occlusion. That's when people have this terrible chest pain because of the infarction that's developing. And if you're really unlucky, that will be associated with an arrhythmia that's not treated, and they will die. As I said, about 30% of people will actually die of their first heart attack. And that is what we are dealing with, this unpredictable disease which cannot be detected by looking for severe narrowing that occurs in plaques which are vulnerable to rupture, which are insignificantly narrowed, so you don't know which one it is, and that will have this event at some unforeseen time in the future. In fact, if you follow people and you do autopsies of people who died sudden cardiac death, the rupture-prone plaque that has led to the sudden cardiac death is insignificantly narrowed in 2/3 or 3/4 of the cases. Only 1/4 of the cases, you could say that the lesion was severely narrowed to begin with. So this makes, of course, prediction and so on very difficult. Now, the second thing we do is that when we see these lesions, we revascularize them, meaning we angioplasty them, open them up, or we do bypass surgery if there are multiple lesions like that in the coronary circulation. So here was a study, and it's one of many studies that have been done over the years, which have asked the question, should we treat blockages, meaning these severe narrowings, more than 50%, especially more than 70% narrowed, should we angioplasty them because they're there? Or should we treat them with bypass surgery if there are many of these? Or is medical therapy good enough? So this was a randomized study looking in people who didn't have left main disease. So there are people who have been removed from this study, those who had heart failure, low ejection fraction, or those who had left main disease. The rest of them were randomized to either receiving medical therapy or they had to undergo angioplasty or surgery, whichever one was suitable. And what this shows is there was no difference in outcomes. So just because there are blockages in your coronary arteries, it doesn't mean that you should go around having angioplasty and surgery necessarily. Of course, there are all these provisos that you shouldn't be having a heart attack and you can't have low ejection fraction and the narrowing cannot be in the left main. So the majority of people can be managed medically equally as well, as long as their symptoms are well controlled. So then the question is, how do we get to all of this? How does coronary disease actually occur? So we can step back a little bit and ask how the lesion goes from being, or the vessel goes from being completely normal to developing this plaque. And a lot of, a sort of a revolution occurred back in 1980, so it's now almost 40 years ago, it seems a long time, where this Nobel Prize winning group discovered the fact that there was, the endothelium was what was becoming abnormal in its function as a result of exposure to these risk factors like hypertension, hypercholesterolemia, and diabetes, and so on, and with aging. So nitric oxide, which is, I won't spend too much time on this, is the main driver of this health of the endothelium, and these abnormalities of this layer of the wall of the blood vessel allows the development of the first abnormality in our arteries that subsequently leads to plaque development. And we have spent years studying this. And so has Dr. Shabi Zaidi, who introduced me, where we have ways of testing this in the human circulation. Here's looking at the brachial artery endothelial function or the microcirculatory, and here's the coronary artery studies, etc. So we now have a very good understanding that the reason we shift from all of these risk factors to developing this disease in our arteries where plaque develops and then ultimately might rupture and lead to these acute events. And finally, perhaps the demise of this individual is because the endothelium becomes dysfunctional. As a result of that dysfunction, there is leakage of this, and so it allows in lipids and other inflammatory cells that then invade the subendothelial layer. And as they invade the subendothelial layer, there's necrosis, there's deposition of calcium and fibrous tissue, smooth muscle cells from the media migrate in there. And this area starts to expand, and this is what a plaque is. So it's a very active inflammatory organ, which can eventually lead to either severe stenosis and symptoms of angina, or can be vulnerable to rupture and lead to acute coronary events. So moving forwards with this person, he also tells us that he has a family history of heart disease, especially at a young age in his brother. So this is considered as an independent risk factor for developing this condition. So what do we know about genetics of coronary artery disease? So we can expand this understanding of what we know about risk factors, atherosclerosis, and bad events to what the genetic influences are and the environmental and psychosocial. So a minute on each of these. So back about 15 years ago or so, we had the opportunity, because the Human Genome Project had completed and the whole genome was described, and there were now chips available where we could study tens of thousands of genes with a single test in individuals. And we and many other groups, and this is a group in Iceland that we had collaborated with. Iceland has about only 200,000 people, and they've all been genotyped and all been followed. So it's very easy to do these studies, and they marry each other, so you can get a lot of good data from that population. Nevertheless, we compared this, their population and our population, people who had had previous myocardial infarction versus those who hadn't, and realized that the most common genotype that was associated with myocardial infarction or heart disease or coronary disease was this abnormality, a variation in chromosome 9p21 in that area within the gene. However, the increased risk was only about 20 to 30% for people who had this genetic manifestation not. And these studies were reproduced by several other groups in Canada and the UK. However, within the last 10 years or so, we've now discovered that there are more than 150 other single nucleotide polymorphisms or SNPs or variations in our genome that are associated with coronary heart disease risk. So there are many, many areas. It's a polygenic disorder. It's not like Huntington's where there is one mutation and you get the disease or you don't. This is something that has a little bit of influence, if you like, from each of these more than 150 areas within our genome that are inherited. And so the question then becomes, can we make a gene risk score, meaning you see whether each of these SNPs is abnormal or not, and then create a gene risk score. And these are studies that we've done some years ago. These have been now repeated in much higher numbers. And you notice that if you have a higher dose of the gene risk score, so this is the 5th highest quartile, these people are much more likely to have myocardial infarction at a young age, almost a 2.5-fold or 3-fold increased risk of having early myocardial infarction if you have a higher dosing of these genotypes that are associated with coronary disease. And in fact, these larger studies have also shown that in the highest tertile of this gene risk score, you have almost 70% increased risk of having disease. Now, how do you compute this? What's the 70% increased risk equal to? So if you smoke, you have about twofold or 2.5-fold increased risk. So this is less than smoking. If you have diabetes, 2.5-fold increased risk. If you have hypertension, it's twofold increased risk. So this not even twofold. So it's a relatively mild risk factor, at least the genetics that we can measure so far, genomics that we have. And the curious thing is that the family history of coronary disease still is an independent risk factor, even if you genotype the population. In other words, there are things within family history that are giving you this added risk that are beyond the genotypes that we can measure currently. And that's a long discussion, so I won't go there. So the message about genomics or inheritance of coronary artery disease is that it's a polygenic disorder. There are many, many polymorphisms that are associated with increased risk of coronary disease, but each one of them have very little influence. And testing for this may be only of value very early in life, because later on in life, it doesn't really add much to our risk stratification. And that family history of premature coronary disease is still an independent risk factor, even if you get your genome worked out. Now, what about psychosocial and geographic influences? So you'll find that in most countries, especially in the United States, and these are maps from CDC that are looking at the prevalence of coronary disease around the US, where darker areas depict areas with higher mortality and evidence of coronary disease, prevalence of disease. So you can see back in the 1970s, if you go back almost 40 years, and here it is, this is in the early 70s, much of the population in the North and Northeast was affected. But as we get into the 90s and the 2000s, a lot of that is now occurring in the Southeastern states. And county by county, there could be a 10-fold difference in the occurrence of this disease. So it's everywhere. However, the degree to which it affects the population can be very geographically heterogeneous. And there are many reasons for these differences. A lot of them are to do with socioeconomic status, provision of healthcare, and so on. These kinds of differences are less seen in countries like the UK, for example, where there is nationalized healthcare and there is more uniformity of healthcare delivery, which unfortunately in a country like this, where I am, US, we don't have. So there are important other psychosocial impacts on coronary disease, even beyond these risk factors of hypertension, hypercholesterolemia, and diabetes, etc. Here's our database of our patients. We have a large database of about 8,000 people who have coronary disease that have been collected over the years. We have banked their bloods to do all these genomic and other studies. But we also have a lot of social and psychological information on them that we capture by questionnaires. So here's a question that was asked: what is the level of their education? And notice that people who had college education, meaning they were highly educated, they had much better outcomes when they have coronary disease as opposed to people who are less well educated. And this is almost like smoking, okay? So your risk of having bad outcomes once you develop this disease is much worse if you are not as well educated as others. And this can be done for income as well. We don't ask people how much money they make because they don't want to give that information. So education is a surrogate for income as well. It's actually a stronger predictor than income is. If you're married, you have better outcome than if you're not married. Again, almost 70% increased risk in people who are unmarried, whether they are divorced or widowed or whether never married, didn't make any difference. But somehow having social support, etc., improves life expectancy in people who have coronary disease. You might have thought this would be reversed, but you're wrong. This is neighborhood income. So if you live in neighborhoods which are high income neighborhoods, you have better outcomes than people who live in low income neighborhoods. And this is by way of depression. So we asked people, the PHQ-9 is a very simple questionnaire of 9 questions. People who answered and got a high score, they had depressive symptoms, they had worse outcomes compared to people who had no depressive symptoms. And this was independent of whether or not they had known diagnosis of depression or had previously been treated with depression. The current symptoms were actually depicting worse outcomes in these people. So there are influences then even beyond the usual risk factors that we generally don't think about when we are dealing with these people. Certainly your cardiologist is not going to worry about these things. And however, they do impact on outcomes of these individuals who develop coronary disease or who are going to develop coronary disease, should be taken care of and should be thought more about in a holistic approach. So the next, in his questions, this patient is asking, why did I have a heart attack and what could I have done to prevent it? So then he's saying, you know, what could he have done to have this diagnosis made earlier so that this wouldn't happen? So here, this is a whole huge subject in itself. You know, how do we manage people? How does primary prevention occur? So I won't have time to dwell on this too much. But at any age, really, even starting in teenage years, should have your cholesterol measured, at least. And this is to detect a very small population who have familial hypercholesteremia and very high cholesterol levels, because that group needs to be treated very early. Otherwise, they'll develop premature disease in their 30s and 40s. But as one gets older, certainly the screening should be done every 5 years or so. And then we use this Framingham risk score, or in this country, we do a pooled cohort equation, which is a modification of this. But there are all these risk scores that every country has. These are all downloadable algorithms where you need to know their age, their gender, and then you need to know cholesterol levels, HDL and LDL values, glucose values, or history of diabetes, and whether they'll smoke or not. So you need these risk factors assessed, and then you can develop a risk score. And basically the idea is that if you have diabetes already, then you should be starting treatment in order to prevent occurrence of premature coronary artery disease. Should be on aspirin, statin. But if you don't have diabetes, then we can use these risk scores and divide people up based on their risk scores on those who are very low risk, less than 5%, 10-year risk of developing coronary disease, or those who have extremely high risk, more than 20% risk of developing heart disease in the next 10 years. And then, of course, you have these intermediate risk people where you don't know what to do. And in this intermediate risk group, between 5 and 20%, one could do some additional testing. And probably the best additional test to do is the calcium score. This is a CT scan of the chest, which allows you to see whether there's any calcium deposition in the coronary arteries. It takes 1 second to do, and it's usually very cheap. However, it detects whether or not there is calcium. And you can see that people who have zero calcium score, and these are large data sets of general population that has been followed for years. These are more than 6,000 people in the MESA study. Who zero calcium score people just don't have any coronary events going forward, so very few. But look at people who have a score of greater than 300. They're up here. And then, of course, it goes up as the score goes up. Between 1 and 100, you're on the red line. And then up to 300, you're on the purple line, and so on. So it's a very easy test to do. It's measured, you get the result right away. It's measured as Hounsfield units, the density of calcium that's within the coronary trees. And this number identifies people who've developed coronary disease even without knowing about it. Whether or you have risk factors, you might get this. And this is a very good way of early detection that can then promote the early administration of preventive therapies like aspirin and statins, and of course the control of the risk factors that have got them there, diabetes, hypertension. So what is the current management of coronary disease and how can we make this better? And so here I'm going to share with you some of the work that our group has been doing. This is what happens. These are 3,500 people that we've been following for years. This is sort of time in days, so it's about 5 years here. These are people ideally treated. They've been managed. They've had angioplasty or surgery if they need it. They've been on good medical therapy, aspirin, statins, et cetera, blood pressure medicines, diabetes medicines, et cetera. Yet there is this risk where they're going to continue to have deaths and myocardial infarctions going forwards. So everybody has residual risk. The 2-year event rate is 12% of people will have either died or had myocardial infarction. 11% will have further narrowings that will require revascularization. So the question is, can we do better in terms of predicting who's going to be on that slippery slope and who's going to do well? And in order to get there, we need to break away from just concentrating on risk factors and understanding the biology of what's going on. How do we get from here to here? How do we get from the plaque being nice and stable and sort of benign to becoming malignant and breaking off and rupturing or eroding and leading to acute events, which then cause damage to the heart and heart failure or death or myocardial infarction? So we know that these processes involve oxidative stress, meaning this abnormality of the endothelium that is preceded by increased oxidative stress. That is as a result of damage from risk factors that leads to this inflammatory reaction when an immune dysregulation, a prothrombotic state, which leads to clot formation and then myocardial injury and so on. And now we have proteins that circulate in our bloodstream that can actually measure these processes. So we are not going to have to biopsy everybody's coronary arteries, but we can measure in their blood signs of inflammation, of immune dysregulation, of thrombosis and coagulation and myocardial stretch and ischemia by measuring these proteins like CRP and heat shock proteins and fibrin degradation products, SUPAR, BNP, and troponin. Some of these are very widely available. CRP, BNP, and troponin. The others are more research-oriented biomarkers. But nevertheless, this is a look into the future of how we might be able to measure them. So when we did this in this population of ours, and we measured all of these 6 biomarkers, and then followed these people up and they had these events, we were able to predict these people based on their biomarker risk score. So people who had none of these biomarkers elevated above a certain cutoff had excellent outcome. These people all had coronary disease. They are matched for all the risk factors, et cetera, and adjusted for them. Yet people who had 5 or 6 of these biomarkers elevated were on this really slippery slope. So that almost 60% of them had died or had a heart attack within 5 years. So this is like having some sort of aggressive cancer, whereas this is like being the general population. And yet we treat everybody the same way. These have all been treated the same way. And within that group, we have this extremely low risk and an extremely high risk group that we should be able to deal with separately. This is showing you the same thing of all-cause death or cardiovascular death, MI events. People with multiple biomarkers positive, all 6 are up here. And this is 5% of the population is up here. 25 to 45% of the population is extremely low risk. And they don't really need any intervention any further, and they need to continue with what they're doing because they are down here. Whereas these people are obviously need to be looked after very differently. So how can we optimize therapy in people who have coronary disease? So this is a nutshell view of how this works. This, of course, would take hours to get into in great detail. So intensification, what does that mean? Well, it means that we have to do a lot in terms of lifestyle and behavioral changes. This is primarily where we fail most because this is not something that comes in a pill. The individual has to do this himself or herself. So smoking, cessation of smoking, exercise, losing weight, and these kinds of things, and diet. And these changes, which is what weight loss is about, are the most difficult to make. Cardiac rehab has been shown to be helpful, can reduce event rate or recurrent event rates in people who developed acute coronary syndromes in particular by 30%, reducing LDL levels to less than 70, at least in the milligram per deciliter units, using higher dose statins in people who have disease already, and adding other therapies to lower the LDL levels. So very aggressive at this. Use of aspirin, intensified diabetes therapies in people who have diabetes, especially with these agents that are known to be cardiovascularly protective, like the SGLT2 antagonists and GLP-1 agents. And then maintaining blood pressure at guideline levels, which means less than 130 millimeters of mercury systolic. And then use of ACE inhibitors or ARBs for people who have left ventricular dysfunction, and aldosterone blockers for that group as well. And if this is not enough to control their risk, then you can further intensify lipid-lowering therapy by these more expensive drugs, the PCSK9 agents that are very effective in lowering LDL, even when you run out of high doses of statins. Addition of antithrombotic agents like rivaroxaban has been shown, particularly in people with extensive coronary disease and peripheral arterial disease, to be protective using dual antiplatelet agents, and omega-3 fatty acids, especially in people who have hypertriglyceridemia. So I know time has gone by, and I think my time is up. Essentially, what we have learned today, and I know this was a little rapid, is that coronary disease manifests itself symptomatically as myocardial ischemia, can cause chest pain in some of us, but a lot of the time it's silent. That concentrating on this for detection is a fallacy, and that managing ischemia by revascularization for symptoms is reasonable, but not in everybody, because it doesn't prevent future adverse events. That there is this whole concept of vulnerability of plaque that can often occur in plaques that are not significantly narrowing the coronary artery, meaning they're not causing myocardial ischemia, yet the person is at risk of having future adverse events. And that attacking the vulnerable plaque and making it less vulnerable requires medical therapy, such as aspirins and statins and ACE inhibitors and so on. That this disease occurs primarily as an abnormality of endothelial function that gets the whole process going. And you can even look for this and can know who is going to develop this disease over time, but we don't do this clinically. That the family history and genomics are important, and there are many, many polymorphisms that predispose us to this disease. But it is a polygenic disorder, and that measuring your genotypes is not necessary to improve your care, and it doesn't really help in risk discrimination at the present time, unless we get to an age where everybody gets genotyped when they're born, in which case you would know that you're going to develop this at the age of 1 month. And then you would be able to not get to smoke and not gain weight and not exercise well, et cetera, so that you would bypass this disease, which you are going to get because of your genotypically determined to get it. That there are important social and psychological determinants that overlay the risk, so that not only is blood pressure and diabetes, et cetera, important, but where you live and who you are and what your psychological status is has important impact on outcomes of this disease. That in the future, we will have specific biomarkers that we will be able to more precisely determine risk in individuals, which will be blood tests and not expensive tests, and hopefully will be available in general. And that the management of coronary disease is fairly straightforward, but it's not done very well. Majority of our population does not take the medicines that they're prescribed. Most of them take it like an antibiotic and stop it after 2 weeks because they feel well. And that's largely because they don't know what their risk status is. And then explaining what's going on, et cetera, and then follow up, et cetera, is going to be critical in achieving good outcomes in this condition, which is highly prevalent. Most of us are going to get it. Thank you very much for your attention, and thank you very much for giving me the opportunity to talk to you.
Thank you, Dr. Kiyumi. A wonderful, wonderful lecture and overview of a very long, tough topic, which you're an expert on, and we've really got a great overview here today. Any questions from the audience? Please feel free to post them on the chat. But I have a question, Dr. Kiyumi, for you. The assessing cardiovascular risk has become so important, and in the UK, in primary and secondary care, we try and do this now earlier and earlier. And often at the age of 40, people are invited for assessment. Do you use any other markers routinely in your practice, such as you mentioned apolipoprotein, which we don't use routinely in the UK, but do you use anything like apolipoprotein or genomics or any of the biomarkers routinely, or are they still for research sort of purposes?
So we don't routinely do apolipoproteins, just like you don't. I don't think there is sufficient increased value in running those once you've done your LDL and HDL measurements. So you really have to be very pragmatic about what everything costs money. So I don't think that adds value. I was just showing that because that's what the study did. The Interheart did that. It's an international study. What are the things we do? It depends who you're looking at, right? If you've already got disease, it's a whole different equation than if you don't have it and you just have some risk factors and you're wondering whether you have disease or not. And I have now become very liberal in using calcium scoring. So I don't futz around and say, well, your Framingham risk score is 7.5%, and maybe we'll wait a little bit and we'll see what happens. And then, because the risk scores are really age dependent. So you could have the same level of cholesterol and sugar and whatever. And when you're 40, your risk score is low. When you're 60, the same makes you very high risk. So why wait from 40 to 60 with all these risk factors for 20 years? And then you get to a level where it's 7.5%, then you can prescribe a statin. Why didn't you take it when you were 40? Because you're developing this disease for the last 20 years, you had the same risk factors. So there is a little bit of fallacy in these risk factors these risk scores, because they are largely driven by age. So in order to overcome that, and if you really want to know, and depend who it is, and it costs money to do the scan, most people, I tell especially I tell our South Asian community, who are extremely high risk for developing this disease and to developing it early because they have such a high incidence of diabetes and dyslipidemias, is to get a calcium score. So I tell the husband to give it as a birthday present for the wife, and the wife to give it as a birthday present for the husband. So they both go and get a scan. And most of the time, they all have calcium, and they get on therapy and they do well. And so that's really a very simple solution at this moment, without getting into all these precision approaches. And I don't do genomic testing because it's not valuable. I mean, we've followed these, as I said, and I didn't have time to get into all of that. It's really the top 1 or 2% that way you can really see a difference in doing genomics. 1% of the population. It's really difficult to impose that on 99 other people where it's not going to be valuable to find that 1%. So, but I think, as I said, it has a role if and when we all get genotyped at birth.
Thank you, Dr. Kumi. There's a few questions from the attendees. I've got a question from Professor Rashid Mahmood, which is asking which patient is more prone to suffer from ischemic heart disease, patient with depression or patient who's anxious with anxiety?
So there is data to suggest both of these are risk factors. I'm not sure I would like to say who has a higher risk or not, because each of these things is not yes, no. There is a level of each of these that probably makes a difference. So the question is, why does this lead to this increased risk? In depression, the thought is that at least some of this is biology. Of course, there are all these pathways that get activated in depression. Inflammatory markers are higher in depressed people. Depressed people don't take care of themselves. They're not so compliant with their medicines. They don't come to appointments. They don't eat well. They gain weight. The diabetes is worse controlled, et cetera, et cetera. So basically, it interferes with every aspect of life. And all the other conditions that they have are always worse off in depressed individuals. Stress is a little different. The stress can be acute stress. It could be chronic stress. And the manifestation, the biological, if you like, the sort of biochemical influences of stress are really quite fascinating. We have a whole program project grant that studies acute stress in people with coronary disease. And maybe next time you'll ask me to talk about that, and I can go on and on about what happens with stress. But it affects our vascular function. It affects the way we signal in our brains. and the pathways that get activated that influence cardiac function, it influences vascular function, and it activates all of these pathways that subsequently lead to acute coronary syndromes and worse outcomes. In fact, we have now got a whole cohort where we have shown by doing an acute mental stress in the laboratory. So instead of doing physical stress testing, they have a mental stress test given these people with coronary disease. And the mental stress is that they sit in front of people that they haven't seen before and make a speech for 2 minutes on an uncomfortable subject. The subject usually is that their relative has been abused and they are going to now go to the institution where they are resident, and you're going to talk to them about it. And you have 2 minutes to think about this and 2 minutes to make this speech. And we put a camera in front of them, and then they make this speech. And that gets people's blood pressure up by 40 millimeters of mercury. They vasoconstrict, and they can develop myocardial ischemia. About 20% of them develop myocardial ischemia during the speech-making exercise. So now that I'm making a speech to you, I may be developing some degree of myocardial ischemia, although I'm not speaking of an uncomfortable subject. So even activities like that can be stressful on some of us enough to cause ischemia. And these people who have that kind of reactivity actually have 3 times higher mortality and infarction rate than people who don't develop that. So it's not just exposure to stress, it's exactly who you are that is going to be exposed to stress that matters as well. How do you react to external? We all are going to face stress. The question is how our reactivity works and what can be done about that. And there are all these studies that are looking at sort of stress reduction strategies, et cetera, to alter the response of these individuals who have such a catastrophic response to stress, et cetera. So that's a whole field in itself. Sorry about the long answer.
Fantastic. Another question from the audience was, in a nationally managed health service, how does one get to do calcium score levels in CT scans?
Well, it must be a UK question.
Yeah.
I don't know. I actually don't know the system well enough to know, but you can pay for it. Like I said, in the US also, it's not approved. Your insurance doesn't cover it, which is similar to what you are facing. It costs $100 here, which might sound a lot of money, but healthcare here costs anything, any little thing costs in thousands. So it's really cheap. So that's why I say it could be a gift at your birthday at the age of around 45.
Fantastic. Yeah, in the UK as well, difficult at the moment. We're using more and more CT, Dr. Kumi, but that's in secondary, tertiary
Right.
care, not via
CT
primary
angio.
care.
Yeah.
CT angio, CT calcium score more and more.
Yeah, no, it's, as you know, the guidelines haven't recommended this. And the reason they haven't recommended it is because of this deluge of testing that will follow. So that
Yeah.
the guidelines are very conservative. They don't just look to see the value of a test, but also look to see how much it's going to cost the system.
Yeah, of course. Yeah.
So, however, nevertheless, it is, you're dealing with a pretty important disease, which is hard to detect, right? There isn't a biopsy that we can do to find this out. And this allows us an insight into something that's already there decades before it's going to kill you. So, and prevention works. So if the system doesn't allow you to get something like this done, and it is readily available and is cheap, then I think it's worth even, doing it yourself.
Yeah.
But it requires a lot of education of GPs and so on and so forth.
Interesting. You mentioned price, because it's getting cheaper to do. The UK national guidelines have indicated calcium score and CT early for those who present in chest pain clinics as first line. So and as you know, UK guidelines are usually take into not just clinical but price, because it's so important in a nationalized service. So we are using more CT. Once you get to cardiology, we're using more CT, but not early, where most of primary care deal with cardiovascular risk at the moment, and so but we are using more. There is another question here, an interesting one. Any role for melatonin in coronary disease or prevention?
Not that I know of.
No, not that
Certainly
I
not
know.
an approved therapy.
Mm. And in utero exposure is interesting to preeclampsia. It says here increases chance of metabolic syndrome and cardiovascular disease. So what are some other offspring complications? Not that I know of. What, any comment on that, Dr. Kiyumi?
So I think this is referring to a lot of work that has gone on particularly in the South Asian population, and there are theories as to why metabolic syndrome, meaning susceptibility to diabetes, is so high in South Asians compared to other populations, right? There are all these UK studies and worldwide studies actually being done to show that the South Asian population, the UK, for example, or Canada, much higher incidence of diabetes, almost approaching 25, 35%. But yet they have low body mass, right? BMI is not that high, et cetera, et cetera. So there's deposition of fat in the liver, there is central obesity, et cetera, et cetera. So there is this whole metabolic syndrome, meaning dyslipidemia, hyperglycemia, obesity, et cetera, hypertension, the 5 things. So the concept is that that this actually is transmitted in utero, that we came from populations that were deprived of calories generations ago. Even, like my generation, when I was growing up, we used to have dessert, sweet, once a month. This was in India. So now we have it continuously. Everything we eat has some sugar in it. So we grew up in this sort of calorie deprived, if you like, circumstances. Nothing wrong with that, but it was, considering how much calorie exposure we have, we used to be deprived. So you develop epigenetically, not genetics, so it won't be in your chromosomal analysis, you'll have to do epigenetic studies. But the epigenetics studies have shown that you develop this thrifty gene. There's this thrifty gene hypothesis. There's certain genotypes that get methylated, certain genes, that increases the risk of, so you're much more insulin resistant. So you can, every calorie you eat is kept and is stored and so on. So you develop that, and then you transmit that to your offspring as well. But the offspring grow up in the UK and the US, or even in the South Asia now, where there is no shortage of calories. So from being very thrifty, you are now flooded with calories and you can't handle it because you are designed to be insulin resistant. So you get your diabetes a lot earlier and all the mayhem that follows afterwards. So that's the hypothesis, that it's an epigenetic effect of living through these times or these generations that were calorie deprived. And there are some actually neat studies during the German occupation of Holland where there was starvation, and the kids who grew up during that period of time actually ended up being diabetic. Even that short 4-year period of starvation that the Germans had inflicted on the Dutch. So anyway, again, a long story, but that hopefully covers that a little bit.
I'm going to hand over to Shifa Baji shortly for any further announcement, but I'm sorry not to get through all the questions, but I want to once again thanks Dr. Kiyumi for a wonderful lecture. We couldn't have had a better person to give us a talk on this, given his recognition in this field. Thank you, Dr. Kiyumi. I'll hand over to Shifa now. Baji.
Shifa, if I could have 1 second, I would just like to mention to this audience that Medics International, IMI, has a journal called Journal of Medics International that we have started, and it's an online journal that Dr. Zaidi, who chairs these sessions, is the editor-in-chief for, that we are seeking articles for this. This is an online journal that you can log on and get instructions of how to send your articles there. It really is a general journal. Our focus is on many different things, but essentially it's international. We would like articles on virtually any field that you're working on, but it'll also have concentrations on fields of medical ethics and so on. Here's what a website looks like: JMI, Journal of Medics International, at imamiamedics.com. And we also have, if you don't like to write long articles, we also have space for short, like one-pagers, newsletter. This could be an abstract of an article that you're working on, or you presented, or subject that you're interested in. And this will also be a periodic publication that will go through all of the Medics International membership. Thank you very much. Sorry, I'm done.
Thank you so much, Dr. Kayumi, for your lecture and for the early morning lecture that you've given us. And we hope to have you back very, very soon. I just wanted to share the schedule for the upcoming lectures. We have our next lecture coming up in about 2 weeks. And okay, let me just so we have a very nice lecture series that continues again for next month, starting on February 6th at 11 a.m. GMT, so the same time in 2 weeks, with our faculty speaking on the scholarship of teaching and learning. So the medical education webinar followed by a clinical webinar by Dr. Naweed Sayed of Canada. So again, I'll welcome you all back again very soon for that. So thank you, and see you all very soon.
Thank you.